Good morning, everyone. How are you doing? We're almost halfway through ASCRS, and I'm very, very pleased to welcome all of you here in the company of Dr. Alison Chiu and Dr. Ahmed. Please welcome. And today we're going to talk about our AddOn Lenses. And I'm very happy to have these two amazing, wonderful surgeons with us who are going to share their experience with the AddOn lens.
Thank you so much for having us here, Nikki. Thank you, everybody, for coming. I just wanted to say something to you. I hope you don't mind at the end. A lot of people are here. They're going to want a photo with me.
Yes,
so
yes,
if you don't mind taking the photos, thank you very much.
I would be my pleasure. Thank you, everybody, for being here. I hope you can hear us and come closer if you can't.
So let me just say a few words about our two experts today. So we have Dr. Alison Chiu from Sydney, Australia, a fellow trained ophthalmologist specialized in complex cataract surgery and lens and laser-based refractive surgeries, working both in public and private practice. She studied her PhD at Cambridge University, University College London, and the University of Sydney, and continues her academic pursuits by teaching and examining for RANSCO, the Royal Australian and New Zealand College of Ophthalmology. And we also have Dr. Ahmed. I think we could sit here all day long if I read you all of his accomplishments. So Ike, why don't you tell us about your experience with AddOn and how you got involved in Medicontur?
Yeah, well, thank you so much, Nikki and Alison. Great to be here and great to see everybody here. So, my first experience with actually Medicontur was live surgery. And I'm in the OR. This is in Brazil, and I had a chance to place the AddOn lens in a patient who had pseudophakic monofocal IOLs. This was actually a patient who's an aunt of an ophthalmologist, a very prominent ophthalmologist, and she really, really wanted to have spectacle freedom. And so I was very honored to be asked to do the surgery, and this is me in the OR. It was a very smooth case. In this case, we placed the trifocal AddOn lens in the sulcus, and you can see the loading here. It was a very smooth technique. The patient had one eye done, and the next day she came and she was ecstatic. I mean, literally, she was just like, a whole new world for her. And then the same day, we did live surgery. So I don't recommend the first time to do a lens live surgery. I probably don't recommend this to do it when you learn, but fortunately, everything went very well. The surgery is fairly straightforward, as you'll see. Look at the OCT. It nicely shows the vault. We'll talk about this, the vault between the in-the-bag lens and the sulcus lens. So thank you for the opportunity. It was really great to start with the AddOn lens in my career with Medicontur. Thank you.
Thank you, Ike. So Alison, what's really an AddOn lens? Can you please just briefly sum up?
So an AddOn lens is a supplementary secondary sulcus lens. So this is designed specifically for the sulcus when there's a primary IOL in the capsular bag.
And Ike, many surgeons refer to the AddOn lens as a piggyback lens, a classic piggyback lens. What really differs the AddOn lens from a classic piggyback?
Well, I made the mistake of calling it a piggyback lens when I first thought about this idea. And we do use piggyback lenses from time to time, of course, but there's a significant difference. Piggyback lenses have been used, for example, for high hyperopia, non-ophthalmic eyes, two lenses in the bag, or one lens in the bag, one lens in the sulcus. But these lenses are not designed for sulcus. First of all, they're vaulted typically, 10 degrees vaulted. They're open loop haptics, which can rotate. So really, this is not the same concept as a traditional piggyback lens, and that's why I think it is appropriate to differentiate piggyback lenses from an AddOn secondary sulcus lens. I think that's a significant difference in nomenclature.
Yeah, and we definitely don't see any issues with interlenticular fibrosis or lens touch or anything like that either because of the way it's designed.
Right. And Alison, the AddOn lens can cover a very wide range of indication and can be used in many different approaches to improve patient outcomes. Can you please share about the portfolio and available lenses from
That's
First
right.
View?
So we have the monofocal toric, multifocal toric, as well as the Charioth macular lens, which has a high NIRAD for your dry, stable AMD patients.
Ike, who's the best candidate for an AddOn lens?
So first of all, I'm guessing how many basically use a sulcus lens? I'm curious. Yeah, we often use it. And what about two lenses in the eye? Some. So, I mean, I think it's a bit of a foreign concept, I'll be honest, right? I mean, we have a lot of different lenses out in the market. But the role and the idea of having a secondary lens is an area that I think we haven't really explored. We have many patients who, for example, have had a monofocal lens in the eye. They would like to have extended depth of focus or full range of vision that are now a candidate. We have patients with residual astigmatism that we wish to use a toric lens or residual spherical error. Now, I have experience using piggyback lenses in those scenarios, but they're not ideally designed. They may rotate, they may cause chafing, they may cause interlenticular pacification. So those are the typical candidates that we would look at that. And I'm quite intrigued, for example, in patients who primarily were doing surgery, where they may have a high degree of cylinder, maybe they have an uncertainty about their cylinder or their cornea, maybe there's uncertainty whether they're going to be a candidate for multifocal lens. So you may decide to say, you know what, we're going to use a dual approach, put both lenses in the eye at the same time in primary surgery. So I think there's a lot of opportunities. I realize this is still early in people's minds. I think we're going to see, though, the concept of matching a sulcus lens as needed and customizing it for one eye or both eyes for patients who need it either primarily or secondary. So those are some of the candidates. And we started to consider this where patients maybe we consider to do LASIK or a PRK touch-up, for example. We don't want to touch the cornea. We go back into the eye. A sulcus lens is a very tolerable place for lenses, as we know. Or primary cases, as I said earlier. So that's the kind of cases that we're typically looking at.
Alison, do you have anything to add?
Yeah, so I've also used it in cases where the astigmatism correction is really uncertain preoperatively because the cornea is very aberrated or scarred and you just can't work out what's going to be the most appropriate toric lens to put in the bag. So I've put a primary lens in the capsular bag and waited 6 weeks or so, obtained 2 subjective refractions at least 2 weeks apart to determine the astigmatism correction. And this also works for keratoconic eyes with marginal pellucid degeneration, where you don't know how much of that astigmatism is irregular versus regular. And you can tease that out with your subjective refraction post-operatively by correcting the regular amount and determining the astigmatism correction. Other ways we've used this lens is when there's specifically a hydrophilic lens in the bag and the patient needs a DSEC, and we've used a sacrificial add-on IOL in the plano to protect that IOL in the bag from potential opacification from the air bubble during DSEC surgery. And it can either stay in place or you can go in and remove it down the track. Other ways we've used it, as Ike said, is post-operatively if patients haven't had discussed with them premium IOL options and they have either a non-toric in the bag or a monofocal in the bag and they need a vision upgrade, either with a multifocal toric or just the monofocal toric to refine the vision. It's especially useful, when there's a higher sort of hyperopic refractive surprise as well, because these are not ideal laser candidates and not all cataract surgeons have access to a laser. So I really like using it in those instances.
So we covered the indication and the use of the lens. How do the features of the lens differ from other competitors on the market? And how do this lead to better patient outcomes, Ike?
Yeah, I think that the design and the optics are really important. And, currently available lenses in the bag, we sometimes use them in the sulcus, 3-piece lenses, but they're not optimized. And I think there's a couple of things that are important. First of all, the lens should be vaulted, so it's not touching the lens in the bag that's present. So this is, you can see, a vault that keeps it about 0.5 millimeters in front of the in-the-bag lens, number one. Number two, it's important that it's rotationally stable. So rather than open haptics, you can see there's a 4-haptic design that really keeps it nice and stable. Number three is it should be thin because we wanted to avoid, of course, contact with the iris or other issues with spacing. It's a very thin lens. It's about 1/5 the size, about 200 microns of a regular in-the-bag lens. That's important. We also want to make sure we prevent it from chafing or from getting caught in the pupil. And the quadratic design, which is designed there to prevent that, is there. So I think, all the features there, I think, are there. I don't know how many of you do ICLs. If you do ICLs, you may know that ICLs has really taken off. I look at this as being the ICL for pseudophakia in some ways, because the ICL is designed for the sulcus. This is designed for the sulcus in a different indication. So that's kind of how we look at it, and I think that it opens the opportunities, as I said earlier.
Anybody doing ICL surgery also knows that the biggest pressure point is sizing that lens correctly. However, because this is so rotationally stable in the sulcus, we don't have to worry about the sizing, and it's a pseudophakic eye, so we have more space. So just talking about the space requirements, there are requirements. You need to have 3 millimeters from the epithelium and 2.95 millimeters in a phakic eye. If you're thinking about doing a dual approach where you're putting one in at the time of the cataract surgery, at the time of the primary lens insertion.
And Alison, how do you calculate an add-on lens?
So if you're doing a primary dual procedure, then what you're doing is putting all of the emmetropic correction in the capsular bag. And usually in that instance, you're putting in a multifocal add-on that's planar. And the reason you're doing that is to give some potential reversibility to that multifocal IOL, because we're always worried with multifocal lenses that our patients may not tolerate the dysphotopsias. Having said that, I've never had to explant a multifocal add-on because the material is excellent, has a very high Abbe number, so low chromatic dispersion. Importantly, it has only 6 diffractive rings, so the dysphotopsia profile is very low. In terms of calculating the add-on lens when you're doing a secondary procedure, then it's based solely on subjective refraction. So you wait for stability following the primary surgery. And of course, some of these patients are presenting a long way down the track, but really I just get 2 subjective refractions that are stable, a minimum of 2 weeks apart, any time from 4 to 6 weeks after the initial surgery. Then you go online onto a calculator, you enter your subjective refraction and other details. It's very easy to use, but also your local Medicontur rep always helps me.
That is true. And about more practical tips for loading, surgical techniques, what should be considered when using and implanting an add-on IOL?
I think this is, I don't want to call it simple because we shouldn't, we need to recognize that what we do is very technical, but it's fairly straightforward, literally. Make an incision. I typically use a cohesive viscoelastic, inflate the sulcus, obviously get good dilation, inflate the sulcus. The lens is fairly straightforward to inject. We typically can use about a 2.5 millimeter incision, as you're seeing in the video, and the implant just nicely glides into the sulcus. As opposed to in the bag, the attack angle is a little bit flatter. We can place it in the AC and place the haptics in the sulcus secondarily, although usually what I'll end up doing is try to get the leading haptics under the iris and then get the trailing haptics to dunk them in with a second instrument. And you see the video there. It's a very controlled delivery, as you can see, unfolding quite nicely. And a second instrument I think is nice to have in the eye to either manipulate the iris or to help it to unfold. And just do it nice and gently. It's a fairly straightforward procedure. Now, as far as removal of viscoelastics, I typically do it manually. I feel it's a bit more controlled. And then you can, if you wish, place a miotic just to make the pupil come down. But that's typically what we're doing here. This is basically a trifocal add-on, as you're seeing there. And I'm pasting the last haptic into the bag. And that's pretty straightforward. Hydrate the incisions and you're pretty well done. So I think that's kind of where this technique is a fairly intuitive approach in placing the lens in the sulcus.
Yeah, I have a few things to add to that as well. So, like Ike said, I like to get the distal 2 haptics into the sulcus first. You have to be particularly mindful when you're implanting this lens over the top of a toric lens. if it's at a primary procedure, because that toric lens is not yet stable. And of course, you don't want to be rotating that toric lens underneath. So that's why it's helpful to implant the first 2 haptics and then rotate your add-on lens into position and then implant the second 2 haptics. In addition, when you're implanting a lens at the time of cataract surgery, so the dual procedure, I find it very useful to vacuum out the viscoelastic from the capsular bag first, and then sort of start again, where you go back in with the viscoelastic and place it into the sulcus. Because once that lens is in, it is, more difficult to get the viscoelastic out of the capsular bag.
Maybe I can add a few points. I mean, there are certain cases probably where we may want to avoid using the add-on lens. I think I would be careful in a nanophthalmic eye, a short eye, a very small eye, where the sulcus space may be a concern. If the patient has weak zonules, we have to be mindful of that. I would be very careful because we need to have zonule support. In some cases, we may find many years later there's a thick Sommerings ring present. So we want to be careful because that can cause some tilt, so be mindful of that. That can usually be readily examined. I don't know, Alison, if you're doing this primarily, whether it's important or helpful to do any capsule polishing, maybe to avoid perhaps some of the potential proliferation of LECs. But, I think those are probably some of the considerations when we think about where to be careful in using, a sulcus secondary lens. It's not a lot of reasons not to, but those are things I would think about as far as being mindful in those cases, Or somebody maybe who's very an unstable, refraction perhaps early on. So I think those are kind of the things I would think about as far as being careful a little bit.
You also have a nice loading video from you, Alison. Can we please put it on the screen? And can you, Alison, elaborate how to properly load a
so I'll talk through this video. It will come into focus. So just at the tip of the Kilmer-McPherson forceps, there is a little notch. That's how you orientate the lens. So there are 2 little notches that really you can see under the microscope very well. I load this in a valley style, and the reason I load it that way is I can then ensure that the haptics are really well tucked underneath that small flange. And that's one of the crucial points about loading this lens. You've got to have the haptics well tucked, like any other lens, but these haptics are fantastic in the sense that they're so rotationally stable, but they're the most fragile part of the lens. And we need those haptics to be intact when we implant the lens for the rotational stability. You don't want to shear off one of the haptics. The other thing is when you're injecting it, because it's a hydrophilic lens, it will unfold much quicker. That's natural for that material to do so. But you just want to implant it very slowly, as Ike alluded to earlier, particularly when you're implanting the last 2 haptics, because they will come out more quickly, and you definitely don't want the plunger tip overriding the haptics because they'll shear off that way. So just slow it down when you're doing this surgery, and that's the main tip.
Yeah, I think loading does take a little bit of finesse, as you said, to kind of make sure it's loaded nicely, and be mindful as you're progressing with the plunger to make sure that you're not overriding the haptics.
Yeah, and you don't want to overfill your loading bay with viscoelastic, because then it makes it hard to seat the lens. So just a little bit of viscoelastic, a little bit behind the lens once you've shut the cartridge. And it's also important when you're placing that small bolus of viscoelastic once you've closed the cartridge that you're not disturbing the haptics, that you're just very mindful about everything that you're doing, slowing everything down.
So we're getting to the end of our conversation. To wrap up, do you have any final thoughts? Alison, you want to go first?
I do. So, many people in this audience, and IQ may not know either, but I'm one of 2 sets of twins. And sometimes I would say that 2 is better than 1. 2 lenses in the bag, 2 sets of twins.
Yeah, I would. Is that you? Okay. That's 4 now. Wow, you're going crazy. Well, I think at this meeting, there's a lot of interesting technologies. This is certainly a little bit of a niche technology. It's not going to be something that you probably will do necessarily every day, honestly. But I always feel that when we practice, the ability to take care of special patients adds more meaning to our day than just the usual patient, you know? Whether it's a complicated case or a patient that takes more time, I think it's worth taking that effort because you have a more meaningful experience because of the special requirements that you can provide. So having that skill and ability, I think, is important, whether it's this lens or any other technology. So, you know, there are patients I think that maybe we overlook that may benefit from these type of technologies. And for me, at least, it's kind of opened up a bit to say, hey, you know what, we have something to think about. Well, before maybe we wouldn't even consider it. So I think it's important to maybe have an open mind, think about it. You'll probably find somewhere maybe that there might be a patient that comes into your practice that may benefit from that. I have a lot of patients that honestly wish that they had a multifocal lens or an EDOF lens. We have patients with residual astigmatism that, you know, kind of are left, or maybe they are gone to a corneal treatment. So there are actually, interesting enough, a lot of patients out there that may benefit, you know. And so I'm particularly excited about the secondary options. I think primarily, as you said, for primary surgery for patients that they're on the fence, will they be a good candidate for multifocal or not? Is their astigmatism, reliable or not? I think doing it as a primary is also an indication. So I just want to just leave with those thoughts, and maybe there's some questions perhaps, but happy to discuss it more.
Thank you for sharing your expertise. Do we have any questions from the audience? It is the time.
There you go. Here's a question. From Germany.
From Germany, yes. So we have Ahmed here, the godfather of glaucoma surgery. So do you still think that MIGS are possible and an option to do after that surgery? For example, iStent or Omnio?
So yeah, sorry, I can't hear, but I heard it from Alison. So are MIGS an option with these? Yeah, I think that there's no reason why we couldn't do a MIGS procedure. I mean, of course, we're using this in eyes that are normal size, good AC depth. The angle stays fairly open, so I think it should be no problem. In eyes that are very small, of course, I would avoid this anyways. So I think it's a reasonable option. I've not done anything combined with MIGS, but I think it would be not unreasonable to do it. I like the way you're thinking, though.
Do we have any more questions?
Who's this guy?
Yeah. My question is that I'm observing that you and most outside of Germany are folding the lens upward like the normal capsular lens. And basically this lens was conceived, do you hear me? Yeah. To be folded upside down. So the haptics are going down. You have to be careful not to put them into the capsular bag, of course, but I mean, it's maybe more safe than the haptics looking up. So my question is, was it just intuitively on your side, or did you try both, or how did you decide to do it like the capsular bag?
I think that's a great question because we're supposed to fold it in the mountain version, not the valley.
Most
and
do it
I
like
think
that.
that's a good point. It really was just intuitive, and you adjust your injection technique and angle accordingly. And I think that, primarily loading lenses in that way, I don't usually load the capsular bag lenses, but, when the nursing staff have problems, you get asked to do it, so you have to know how to do it. So I think you're right, Laszlo, it was just intuitive that this is the way that we're used to loading the lenses. But also there's another point. I like loading it that way because I can really ensure that the haptics are well tucked, because I can visualize them that way.
Yeah, and I think that, the injector cartridge itself has a couple of wells, right? So it's kind of a natural inclination to have the optic sitting into the well by historical experiences. And I think the haptic tucking is important. And you can see it a lot easier when it's like, a talk. We call it taco, like a taco, as opposed to reverse taco. So, but I think we're probably going to see different ways and continue to see evolution in the injector technique.
There's an injector coming out soon with bevel down, so you can fold the lens like you're used to, and it will come out bevel down, fold it down. I hope you don't turn around then.
Any other questions? Any questions?
Hello.
How are you?
Fine, thanks. I'm Pilar from Barcelona. I want to ask about the material. I think you said it's an hydrophilic lens, no?
Hydrophilic, yes.
Hydrophilic, and it's compatible with IOL in the bag, hydrophilic or hydrophilic?
That's correct. It's
Hydrophobic?
compatible with any lens in the bag.
Yeah, but
Hydrophilic or hydrophobic.
but you can use it with lens in the bag, hydrophilic or hydrophobic. It's
That's correct. Yes, absolutely.
compatible. Okay.
Yes.
Thank you.
Do we have any more questions maybe? Seems like no more questions. Thank you so much everybody for the attendance. I hope you're gonna
Thank
have a
you.
great day. I hope you enjoyed. See you around. Bye-bye.